Yes, thank you for the kind introduction. My name is Jeehoon Kang, and I work at Seoul University Hospital. And my topic will be lifetime management for severe AS. I think that this presentation will be a wrap-up of the previous speeches because it starts with diagnosis of the severe AS, and then selection of the treatment option, and then if we perform TAVI, accurate measurements, and selecting the best device for this patient. But still, I would like to focus on TAVI and the procedure, after the process after TAVI, how we perform lifetime management in TAVI patients. We all know that TAVI has a wide expansion of the patients that we treat, which start from very futile patients and now goes to low-risk patients and then younger-risk patients. So in the current era, we're treating very young patients which are defined as younger than 65 years old. These patients definitely have a longer lifetime expectancy, and in these patients, we're Korean patients, we can estimate that we have to treat these patients for more than 20 years, regarding that the actual lifetime expectancy in Korea is about 85 years old. What's more important is that we all know that it takes about 10 years for a valve to fail. That is structural valve deterioration in surgical valves. So this might be reflected to the TAVI procedure. So if we're treating 65-year-olds with TAVI, we should consider that we have to do a re-intervention within about at 10 years and probably 2 times in these patients. So then the early TAVI trials were usually focused on mortality, stroke, the quality of life, and conduction disturbance, which were based on the procedural success metrics. But now we are more focusing on lifetime management. This is a very nice term that we should focus on, and it's more important in the low-risk patients, which have a very low risk of mortality or stroke or any kind of deterioration of quality of life. So this includes hemodynamics, patient prosthesis mismatch, the durability, the coronary access, which is more important in the patients that we treat in the future. So this is the usual Kaplan-Meier curves that we usually saw in the early phase TAVI trials. However, we cannot see these kinds of shocking Kaplan-Meier curves, whether we focus on other aspects that are more important. So there's a shift in what matters, and this is all related to the issue of lifetime management. We can think about a couple of issues which include how long can a single device last? This includes the bioprosthesis valve dysfunction issue, or how can we minimize the mild procedure-related side effects, which is patient prosthesis mismatch or AV block? Or in whom and when should we consider future intervention, which includes not only PCI, but any kind of valve-in-valve procedures. Also, to prevent any kind of future intervention, what is the best medical therapy that we should do to preserve the function of the first valve? This includes antiplatelets, anticoagulants, which I will explain in the following slides. First is the durability issue. From the surgical background, we know that valves failure at about 10 years. This tried to be represented in the TAVI field, and we have a concept that is hemodynamic valve deterioration or bioprosthetic valve deterioration. The surgical field has well shown that though in patients with any kind of hemodynamic valve deterioration, this is highly associated with mortality, which is very important. Therefore, we should prevent any kind of hemodynamic valve deterioration in the patients that we treat. So regarding the hemodynamics, this was usually stressed by the supraannual type valves, showing that a pooled analysis that compared to the surgery arm, that the supraannual TAVI valves had better hemodynamics, and also this included a very nicely drawn Kaplan-Meier curve, showing that hemodynamic valve deterioration may be better in the TAVI arm because these devices were supraannual valves with a large EOA. Also, in the NOTION trial, which discussed the concept of bioprosthetic valve deterioration, also compared TAVI with SAVR in the lowest population, again showed that the hemodynamics was better in the TAVI compared to the surgical arm. So based on these kinds of findings, we can estimate that probably the survival may be better in the TAVI arm compared to the surgical arm based on the superior hemodynamics of the TAVI arm. When we go into bioprosthetic valve deterioration, again, we can see that the TAVI arm was better compared to the surgery arm. However, interestingly, during the long-term follow-up, we can see that there was no difference in any kind of ultimate mortality, despite the superiority in HVD and BVD in the TAVI arm. So this was a very shocking moment because we previously thought that hemodynamics valve deterioration could translate into clinical events. However, that was not shown in the NOTION trial. So maybe hemodynamics equals clinical outcomes may not be an issue that can be easily represented in the current era. Also, when we go into one step more into bioprosthetic valve deterioration, which is bioprosthetic valve failure, which includes death, any kind of reintervention, and severe HVD, we can see again that there's no difference in between the surgery arm and the TAVI arm. So again, this gives us the issue whether we are using the nice definitions of bioprosthetic valve deterioration, because this does not have any clinical implication in valve failure or any kind of clinical outcomes. I have to talk about the SMART trial, which again discussed the issue of bioprosthetic valve deterioration. This study, as everybody knows, randomized patients into the Evolut arm and the SAPIEN arm and compared the clinical outcomes and the bioprosthetic valve dysfunction during a one-year follow-up period. The clinical outcomes were identical. However, we could see that there's a large difference in the bioprosthetic valve dysfunction, which shows superiority of the self-expandable valve. So again, if we cut down the clinical outcomes, there were no difference. And also, most of the bioprosthetic dysfunction was mainly driven by hemodynamics, which again shows that probably hemodynamics does not translate into early clinical outcomes. So this trial tried to stress that self-expandable may be better than bioprosthetic balloon expandable valves, but if we do not have any difference in clinical outcomes, it's very difficult to appreciate these kinds of results. So does this trial mean that self-expandable valves is better than balloon expandable? And also, is it the difference of supraannular or is it the difference of self-expandable? So this is a very complex issue that should be addressed in future trials. The reason that we focus on hemodynamics is because we have very obscure cases like this. This was an 80-year-old male who received a SAPIEN 20 milligram, a quite small valve, again received PCI during the index procedure. During follow-up, we could see that the AV mean pressure gradient was getting up until about over 20 millimeter mercuries. However, in CT scan, we could see that there was only a mild halt, which was shown in one of the valves. So in these kinds of cases, should we consider additional treatment in the future based on the increased pressure gradient and any kind of mild halt? Probably if the patient is non-symptomatic, as I can see right here, I don't think that we should consider any kind of reintervention, but probably, again, it's very difficult to estimate that this kind of mild halt could have any impact on this increased pressure gradient. Probably this may be attributed to the small SAPIEN valve that we implanted in the index procedure. Then is it the hemodynamics that is important in these kinds of cases? The second issue is about coronary intervention, commissural alignment. Dr. H.S. Kim addressed this issue regarding the accurate valve. And this is important because a lot of studies showed that more than 50% of the patients have a concomitant coronary artery disease, and this means that these patients may be candidates of PCI in the future. We also have cases like this. The patient received a TAVI with the Evolut valve. The RCA ostium was nearly totally occluded. Therefore, we performed TCI in these patients. The Evolut valve is one of the most difficult valves for coronary access. So in these kinds of cases, it's very important to ease the procedure to increase the safety of the patients. The reason that we focus on commissural alignment, there's various issues. One of the issues is the coronary, but it's not the coronary. It's because of maintaining the natural hemodynamics of the periosteal area. This is more important in younger age patients and low risk TAVI candidates because we're not only thinking about the coronary access, but we're trying to address that maintaining the original coronary orientation, gives better leaflet motion, it gives better sinus washout, and reduces any kind of leaflet thrombosis, which can give impact in future clinical outcomes. There is various techniques to align the commissure. One of the easiest is the accurate nail valve. The sapien valve, the next generation sapien valve, will have a option that can adjust the commissure alignments. And also the Evolut valve has a C-tab that can guide any kind of commissure alignment. So we can see that all three valves have a trend to increase their options of aligning the commissures or the coronaries. A lot of studies have been performed showing that adjustable options in valves can give a selected coronary engagement, which means that evaluating the coronary access after TAVI is a very important issue. The third issue is about valve failure. How should we intervene and when should we intervene? In patients who experience any kind of valve failure, the orientation is very different because we could not have matched the commissures in the first procedure. Also, because of the failed valve, the CT evaluation is very difficult. This is not only for those who received TAVI in the first procedure, but also in those who received surgery in the first procedure. It's very important to understand the numbers, such as the manufacturer ID, the true ID, whether the previous valve is fracturable or not, and how it looks under fluoroscopy. In case of high struts, we can do procedures such as the basilica. However, even though that the first concept has been shown very long ago, the penetration rate is not that much high because the difficulty in the procedure. And if we see patients who receive valve-in-valve TAVI, not all of the patients need these kinds of difficult procedures. Nonetheless, it's very important to do the very accurate measurements in CT and also understand the numbers to reduce any kind of complications in doing these valve-in-valve procedures. Again, if we do a reintervention, one important issue is the higher incidence of patient prosthesis mismatch. Because we are putting in a small valve within a smaller valve, this gives a high rate of severe PPM, again, which is known to be very bad in mortality. There are various techniques to reduce the residual pressure gradient, such as using supraannual valves, using a high implantation, using various techniques. However, still, it's very difficult to reduce the pressure gradient if there's a small valve in this issue. So this also goes up to the first intervention. If we are doing surgery, whether we should do a root enlargement in these patients. However, again, the root enlargement itself, we're not very sure about the clinical outcomes in those who receive root enlargement in the first surgery. The last issue is about medical therapy to prevent any kind of valve failure. I would like to focus on optimal antithrombotics. And the reason that we focus on antithrombotics is because we have a certain population who have valve thrombosis. The valve thrombosis itself is quite common. However, clinical valve thrombosis is rare. And right now, it's very difficult to find the association between clinical valve thrombosis and clinical events. So if we have a valve like this, have a halt or any kind of restricted leaflet motion, if this extends to any kind of valve dysfunction or any kind of stroke event, various studies have shown various contradictory results, so it's very difficult to ease the association between these kinds of findings. Still, we want to reduce halt, so there was a lot of trials that try to find the optimal antithrombotics to reduce the clinical outcomes or reduce halt in these kinds of patients. However, we could see that a lot of trials have failed in addressing the role of NOACs or dual antiplatelet therapy, which is probably the stronger antithrombotics in these patients. What is very shocking is to see that even compared to warfarin, NOAC did not show clinical superiority in clinical outcomes, which was a very shocking find because it was different from the atrial fibrillation field that we know. So currently, we just use single antiplatelet therapy for those who have no indication for oral anticoagulants. So this is the conclusion of my speech. The indication of TAVI is expanding over to low surgical risk patients, which means that we have to treat these patients for a longer time. And the paradigm of TAVI has shifted to lifetime management metrics. There's new focusing on the hemodynamics, the bioprosthetic valve deterioration, and we try to adjust our procedures to align the commissures. And also, this follows with optimal treatment to reduce any kind of bioprosthetic valve failure in the future. Thank you for your attention.